Good afternoon, everyone. Welcome to the Wilder School Lunch and Learn series at VCU. We're really excited to have you with us for today's session. What is ahead for Medicaid, featuring our speaker, Tracy Douglas, and our moderator, Dr. Sarah Raskin. It's great to see you all. Our free monthly virtual events like this one are all about sparking meaningful conversations and connecting you with key leaders in our community. None more important than today. Join us as we dive into some important topics together. I'm Stephen Dozier, Senior Director of Development at the Wilder School, and I've got a few updates for you before we get started. First, do you want a behind the scenes legislative experience? Boost your resume with our Virginia Capital Semester internship. Gain valuable legislative experience while studying full time. Don't miss this opportunity. Apply now before October 1. Just follow the QR code on your screen. Or are you or someone you know interested in pursuing a degree at the Wilder School of Government and Public Affairs? Apply now before the application deadlines that you see on your screen for spring, summer 2026. You can follow that QR code for more information. There's always something happening at the Wilder School. Don't forget to look at the chat for more links and more info to some of the things I shared here. And now, without further ado, I present our esteemed Dean, Dr. Susan Gooden.
Thank you so much, Stephen, and welcome everyone to our September Lunch and Learn, where we will be exploring a very fascinating and timely topic, learning much more about what is ahead for Medicaid. And we're delighted that Tracy Douglas is our featured speaker today. But before we get to that, we have a great event next week, our Wilder Symposium, that I want to make sure everyone is aware of and hopefully that you can attend. Our Wilder Symposium is focusing on Virginia's elections, our national importance. There are only two states having an election this year, Virginia and New Jersey. So this is an exciting time. Our symposium is always hosted by the namesake of our school, the Honorable L. Douglas Wilder, will be joined by Bob Holsworth, Niraj Verma, Robin McDougall, and myself. So please come, ask your questions, engage in exploring Virginia's historic gubernatorial race. We don't know who is going to win, but we do know this will be our first female governor here in the Commonwealth of Virginia. So please come out next Thursday evening, September 25th from 5 to 7 p.m. here on campus at the W.E. Singleton Center. And now I'd also like to introduce the moderator for today's event, who is Dr. Sarah Raskin. She is an associate professor and assistant chair in our Urban and Regional Studies and Planning program. She is the ideal moderator for this session because she does a lot of work in the health equity space and focuses on community and healthy communities. So Sarah, thank you so much for moderating today's event, and I will turn it over to you.
Thank you so much, Susan. I'm delighted to welcome everyone to today's event. It looks like it's going to be a really exciting crowd. I see so many participants, and I'm really delighted to have you all here. And so what I would like to do next is move our slides along to invite our featured speaker to the stage. So Tracy Douglas is the Chief Executive Officer of the Virginia Community Healthcare Association. I happen to have the privilege of interacting with many of Tracy's fellow folks in the struggle to ensure that we bring healthcare to all Virginians across the Commonwealth, from the far southwestern tip where I grew up and where I do research, all the way up to Northern Virginia and out on the Northern Neck. She is an advocate for rural folks, for urban folks, and really for healthcare for all, and she is extraordinarily knowledgeable about this topic. I am delighted to invite her to present today and to invite all of our attendees to submit your questions into the Q&A link on the Zoom site, and then we will get to them at the end. So without further ado, I welcome Tracy.
Hello, everyone, and thank you so much for having me join you all today. Whenever I get an invite to come and speak about the community health center movement in the industry here, will do whatever I can to make sure that I'm available so that I can speak to the great work of the community health centers. Before we get into some of what I'm going to talk with you all about today, I do want to just show you how the health center movement started, and it is a movement. At the end of the day, it is a big industry. We are the safety net provider here in the United States, but I do think it's important for those of you that aren't familiar with federally qualified health centers and lookalikes out there. I think it's important that we just give you a little bit of history. So we're just going to take a couple of minutes of your time so you can take a look at this video.
It began nearly 60 years ago as a bold experiment in health equity. The goal was to bring doctors to America's most overlooked rural and urban communities, areas that mainstream medicine ignored. With roots in both the civil rights movement and the war on poverty, the earliest health centers had as their mission no less than using the healthcare system to change lives. The first health centers were launched in Mount Bayou, Mississippi, and in Boston, Massachusetts. From there, a revolutionary partnership began with determined doctors, nurses, community leaders, and the federal government to build a community health infrastructure that turned no one away and reached beyond the walls of the exam room to not only prevent illness, but also address the social drivers that cause poor health. That small investment has saved countless lives. The program survived and grew despite many challenges, with health centers coming together to speak with a collective voice to decision makers in Washington. Today, health centers are the largest and most successful primary care network, serving more than 31 million people nationwide. They have earned bipartisan praise for their groundbreaking work to break down the barriers of care, reduce health disparities, reduce ER visits and hospitalizations, and lower healthcare costs. Health centers treat the whole health of each patient with services that include primary care, pharmacy, oral health, behavioral health, and enabling services. They are frontline responders to America's greatest public health challenges, such as natural disasters and a devastating global pandemic. They are heroes, innovators, and troubleshooters. Community health centers are the best, most innovative, most resilient, and most diverse part of America's healthcare system.
All right. So if we can go to the next slide, please. So let me just share with you a little bit and give you a little bit of statistics here with regards to the impact community health centers have on our U.S. healthcare system. So nationally, as you saw in the video, there are about 1,500 health centers with a little over 1.7 million locations throughout the United States, as well as all of our territories. So last year in 2024, you had community health centers that saw about close to 32 million individuals through those locations. And although you see and heard in the video, we are the healthcare system. We are a safety net. We provide, we employ, if you will, physicians. We employ nurse practitioners. We provide pediatric care, women's health services, dental, pharmacy. Podiatry, whatever your little heart desires, we provide that for you. The key about community health centers is that they are located within the United States in areas that, if you will, are challenged by accessing healthcare services. So you will see some health centers that are located in very urban areas, but you'll also see them located in rural areas. For the Commonwealth of Virginia, we have 31 health centers here with 209 locations now. Last year, we saw about 423,000 patients. We employ about 3,800 employees. Our economic impact in the communities that we serve in totality comes to about $420 million that we buy and procurement services and things like that. And then as far as savings for this state alone, we've saved about $190 million. Next slide, please. So we are here to talk about the One Big Beautiful Bill in H.R. 1 and what kind of impact that's going to have on the state of Virginia. And we're going to speak specifically about some of the changes that are going to come down the pike and how it's going to impact not just community health centers in the communities we serve, but also individuals like us, right? So I'm not going to read everything on here, but what I am going to share with you are some of the high level stuff and how this is going to impact. The Commonwealth of Virginia is one of the states that did expand about 3 years ago access to health insurance, and that being Medicaid. You do have to qualify for Medicaid, and there are some qualifiers for which you must demonstrate in order to get that healthcare access. The way it was paid for in this state was what we call provider taxes. And those provider taxes were not assessed on community health centers. They were assessed on hospitals as well as our nursing homes here. So the H.R. 1, the impact of H.R. 1 when it comes to provider taxes is that now the federal government has told states like ours that are using provider taxes to help cover the costs of insuring individuals through our expansion. Is they have now capped how the providers that are being taxed, how they're going to be reimbursed, as well as how much the states can collect to be able to cover the costs of insuring individuals. In addition to that, they are going to be looking that the NCOs now will have to play a part in funding healthcare services within the individual states. In addition to that, many healthcare institutions, including many here in the state of Virginia, do provide certain services. Some of those services have now that are now being restricted, and I will tell you, community health centers are one of those organizations that will have some restrictions imposed on them through H.R. 1. Many states and many healthcare providers have already made some decisions regarding those services, and one of those services is what we call gender affirming care. In addition to that, community health centers, there's a lot of talk right now at the federal level as to whether community health centers should be considered what we call a federal public benefit. Community health centers have never, ever, ever, ever been considered a federal public benefit. We are a healthcare provider. And that being said, if that is the case, then the federal government is, if it's been decided that community health centers will be considered a federal public benefit, then that means further restrictions on who the health centers can see will be imposed on community health centers. The one thing I do want to say about community health centers, although they carry the designation of a federally qualified health center, they are not, and I repeat, they are not federal institutions. They are clearly LLCs, they are 501c3s, they are private businesses that have made the decision that they wanted to apply for the federal designation. So that being said, within that federal designation, they are required to provide certain services, but then there are other services that they can provide that do not fall under that designation. In addition to the implementation of HR1, there will also now be work requirements that will be imposed on all states, whether they're expansion or not, that do offer Medicaid coverage. And what that means is that these able-bodied beneficiaries currently that are able to get their health insurance through Medicaid will have to demonstrate that they are either volunteering or working or taking care of their caregivers. And we're looking at about 80 hours per month that they're going to have to demonstrate that. And then with regards to Medicaid waivers, many states are able to apply to the federal government for what we call waivers that will allow states to take on special initiatives, if you will, to their Medicaid program. Well, now there are going to be some restrictions on how those waivers can be aligned as well as assessed through the federal government. Next slide, please. One of the other things which is really important to us, which we are watching very, very carefully, that did get approved by Congress and signed by the president, are student loans. Just so that everyone knows, we are in a workforce crisis as it pertains to primary care. We have many individuals that are just not getting in the business of pediatrics and internal medicine and OBGYN. We have many individuals that are making the decision to go to medical school, but are really refocusing as to the kind of specialty that they're going to get in. So we are very concerned that by the late 2030s, that we're going to be in a situation where we're just not going to have enough providers to take care of people like you and I. That being said, what's now we believe that's heightened that challenge is the restrictions that have now come down and have been approved through HR1, and that has to do with student loans. Many individuals that do go to medical school do depend on their student loans, and what the federal government has now done is that they are now restricting how much individuals can actually borrow to cover their expenses to educate themselves with regards to clinical care. In addition to that, residents are now, after 4 years of being in more than 4 years of being in residency, they will also have to start paying back their loans, which when they were when they were in residency, they did not have to pay back loans. And so we're really looking at this very closely. And like I said, we are somewhat concerned, and this has raised a red flag for us because we know how difficult it is to recruit individuals to come work in community health centers. We know our hospitals are also experiencing some of the same challenges, and now we've got this to contend with. Next slide, please. The other thing, 2 areas that I do want to focus on this particular slide is ACA Marketplace. And this is an area that is really causing a lot of consternation for us, as well as many other individuals that may not even be on Medicaid, but are actually getting their insurance through the marketplace. And that has to do with these ACA subsidies. They are set to expire the end of this year, December 31st. We are now in a situation where our federal government is trying to decide on funding their budget. And we have just learned that our Congress has decided to extend the budget through November. But did not address ACA subsidies. And what this means is that there are individuals out there, depending on their income, they are able to purchase their health insurance through the marketplace. And we have found that a large portion of individuals that do go to the marketplace are the small employers and their employees are using these ACA subsidies to help cover the premium costs, if you will. We're looking at about a 35% increase overall of individuals that if they lose these subsidies, we are now going to be looking at them making some decisions where they just can no longer afford their health insurance. And then may not qualify for Medicaid because they make too much money. And then what will happen to their healthcare services. So we're very, very concerned about that and what that means for the safety net. The other thing I do want to talk about just real briefly are some of the changes to SNAP. SNAP is the nutritional program through the USDA department. And for us as healthcare providers, we know that many of our folks that see us, especially those who are in the rural communities who have difficulty in accessing nutritious food, they do depend on these benefits. And we are very, very concerned that if they do not qualify for these benefits, because the qualifications have gotten stricter through HR 1, that we may be now faced with a situation where many of our individuals in our communities that we serve will be struggling with proper nutrition or even getting access to nutrition, which ultimately will impact the care that we're providing. And then if you could go to the next slide, please. The last slide I do want to share with you does speak to just real specifically as to the impact to the community health centers here in Virginia with the implementation of HR 1. So you will see to the right of the slide that a large portion of the patients that our community health centers see here in Virginia, a large portion of them do use access their healthcare coverage through either Medicaid or the ACA subsidies. We do have a very large Medicare population. We are somewhat concerned about some of the changes that may come down for Medicare, but right now, we are more focused right now on the Medicaid as well as the ACA subsidies because that will have the impact. We will see that more on the short term than rather on the long term like Medicare. That being said, the community health centers are looking at a very large portion of their patients moving from being insured to being uninsured because either one, they won't qualify for under their work requirements because there could be some administrative issues that could impact on their qualifications. But then also, like I said earlier on the ACA subsidies, folks will lose their access to their subsidy because they will not qualify anymore. They will be making too much money on the Medicaid side. And that being said, we will then start to see folks move over on the uninsured side. Right now, with the way that the HR 1 is laid out, the impact on the community health centers here in the state of Virginia is we're looking at about $22 million a year on the negative side. So what does that mean? So one of the requirements of the community health centers is that they are required to provide their services on a sliding fee scale. Not everybody sits on the scale, but there are many individuals that do take advantage of the sliding fee scale program because of a number of reasons. What we are looking at now is that right now, because we had expansion in the Commonwealth of Virginia, you had a situation where a majority of our patients, because they were insured, we were able to move many of these folks off of the sliding fee program. When you move on to a sliding fee program with the community health center program, you're looking at about $200 on average that you could get or to receive from a patient that sits on the sliding fee program. As you all know, like you saw in the video, we are a primary care provider. We are required to provide multiple healthcare services under one roof at one time for our patients. It is extremely expensive in this United States to provide healthcare services. And so when you're looking at an average and more folks moving over to the SLIDE program and on an average reimbursement of about $200, there's just no way the safety net is going to survive. That being said, if you look to the left, and I'm sorry that the slide is not real clear, but if you look to the left, when you look at the funding that supports our community health centers, I want to be very, very clear. Although our communities health centers are designated as federally qualified health centers, and one of the things that comes along with that is a grant that is funded by our tax dollars. But when you take a look at the overall expenses to run a community health center, the grant does not cover all of the expense to run that health center. So part of the requirement of a federally qualified health center is they are required to have contracts with insurance companies. And there are 5 managed care companies that actually administer Virginia's Medicaid program. And we are required to have contracts with those health plans. We are also required to have contracts on the commercial side as well. So a majority of our reimbursement does come from health plans and health insurance. That being said, when you take our grant dollars and you take our pharmacy dollars and then you take our reimbursement dollars, right now our health centers are underwater for about $110 per patient. So if we see that we're going to see more patients move from insured to uninsured by 2026, and knowing that our health centers are already underwater of about $110 per patient, remember, 423,000 patients we saw last year, I must say that we are at risk of losing many of these community health centers. And if not the health centers, then we may lose some services. And that being said, we also have to look at our free clinics. Do our free clinics have the capacity to take on the patients that our health centers may not be able to see anymore, or because services will be discontinued, will those free clinics be able to take on those additional, do they have the capacity to take on those additional patients? In addition to that, we also are looking at what is the impact going to be on our hospitals, because as a federally qualified health center, we are required to have a contract with our local hospitals for a variety of services like radiology, mammography services, maternal health, delivering babies, things like that. And there is a number of hospitals, rural hospitals especially, that we're looking at in this Commonwealth that we are very concerned with on their future as well. So with that, I am going to end and ask if there are any questions or any thoughts. And Sarah, I will turn it back over to you.
Thanks so much, Tracy. It was a really meaningful overview that you gave in terms of the statewide picture. I encourage our attendees to enter their questions into the Q&A. So let me start with a couple that have already come in. So if you can first talk about the scope of centers or locations of centers in the case of community health centers that have multiple locations. Can you talk about closures to this point? The person who asked the question asked about this year, but maybe if you'd like to situate it within the last couple of years or the last time we saw any kind of big closures, just to give us some trend lines. Thank you.
Sure. Yep. So I'm not sure if anybody was had heard this in the news, but when the new administration came in back in February, DOGE had come in and was doing some assessments on many grantees like community health centers. What they ended up doing were based off of their evaluations and doing their assessments, they felt they needed to make the decision to stop funding the grants. Community health centers use some of those grant monies to help cover their personnel expenses, paying for their physicians and things like that. When there was a cease to our health centers being able to access their funding. There was a health center that was located here in Richmond City that had 4 sites that had to shut down 2 of those sites. There was just no way that they could continue to provide services out of those 2 sites if they could not get access to the funding. We are in that similar situation now. We were able to have some great conversations with our administration, as well as our governor here, to let them know that moving forward, those are the kinds of things that we community health centers just can't take on. As far as the future of the impact of HR1, again, because a majority of our health centers are functioning as with a negative financial, if you will, we are very concerned when a large portion of HR1 does go into effect, which will be in 2026, we are quite concerned on the survivability, if you will, of some of these services that these health centers offered. We are looking at the rural areas. We are about 2/3 rural. And so that being said, our focus right now is we don't want our rural communities to not have the access that they currently have. And so we are really laser focused on all health centers, but definitely those rural areas so that these folks don't get the access. We've got a situation now where maternal health is extremely very fragile in this state, as well as the rest of the country. We've got a situation where there is a health center that we have in the Danville community that is a provider for maternal health. There's been some concern about the local hospital there that they work very closely with on being able to continue to provide services there. If that hospital they're not able to deliver those babies, these mothers will have to go well over 50 miles to get access to delivering a baby. And we're very concerned. That health center is extremely concerned. What will that mean for those patients, those women that they're serving right now?
Thank you, Tracy. Since we're talking, we were just talking about pregnant people. Maybe we'll stay on the topic of special populations, populations who have who the safety net has a long relationship of serving. And so I wonder if you can talk at all about undocumented patients and what we might be looking at in terms of like famous prenatal and emergency Medicaid, for example, for undocumented patients. And then maybe we'll move to some other populations of particular interest to this audience.
Well, the interesting thing about that is we don't ask somebody whether they're documented or not. When you come into a community health center, we are required to see all patients, no matter who they are, and no matter what their ability to pay is. That is one area that we just don't get into. Once you walk through the door, we're going to take care of you. We do know that if the community health centers, if the administration does win on the decision regarding community health centers being considered a federal public benefit, which is not what we think we are, and never have been, then there will be the requirement that our health centers will have to start asking our patients what's their documented status. But that is something we do not do now, nor do we ever want to do, because after all, these are clinicians. The only thing they care about is to keep people healthy. And so that being said, our hope is that we don't have to go down that road. And so for now, we're just continuing to provide the care that we can.
Thank you. And I want to encourage the audience members, as you're sharing your questions, to please put them in the Q&A rather than the chat. And we have a way of working with them on the back end to make sure that we're tracking them. Tracy, the next community of a community set of community members for whom the safety net is so important are folks with a variety of disability statuses. So, for example, intellectual disabilities, physical disabilities. Can you speak to how the proposed Medicaid changes in House Bill 1 would impact waivers for folks with disabilities?
Well, I will say one of the good news about the work requirements, right? So it's the work requirements that really we're very, very concerned about with regards to individuals like that. One of the things that it does highlight is that for those who have disabilities, there will not be that requirement, that work requirement, because there are many individuals that just are unable to work or volunteer their time due to their disability. So that being said, we're very pleased with that decision. And that is one of those things, obviously, that many of us healthcare providers really, really, really lobbied our legislators on. So we feel confident that we're not going to see any really big changes there. The only thing we do worry about, again, is because of some of the impacts that HR1 is going to have on some of our hospitals, especially in the community, in the rural community. We are quite concerned that the referral sources that we work with through these hospitals for our patients with special needs, we're concerned that we may lose those referrals. And so that's one of those things that we are in constant communication. I'm in communication with the Hospital Association, as well as many of our local community health centers are in constant communication with their hospitals, so that we can ensure or at least find some backups if we end up losing some of these services through our hospitals.
Thank you. And just to disentangle this a little bit more, because our audience is interested, in terms of the definition of disability so far as what you just said with regard to the work requirements, do you have any insight onto any potential changes with regard to what able-bodied means so far as working? And would like mental health issues, behavioral health issues that might be a cause for challenges maintaining employment, such as depression, ADHD, anxiety, etc., would those be included, or do you see any world where the definition would become more strict?
That's a great question. And that is one that we're still working through. The one thing we do know through HR1 is for those who have challenges with substance use disorder, that they will not be confined to the work requirements. But they've got to have a documented case that is the situation. On the mental health side, I will say this. I just want to kind of do a little bit of a sidebar on that. This state is one of 40 states, if you will, that has what we call a federally qualified health center that only works with the homeless. That particular health center here is located in Richmond City. We're still trying to work that through. Many of our homeless patients do have some mental health challenges, which are well documented in their record. But we still are still trying to figure out what role the work requirements are going to make. I think a lot of this is going to be up to the state. Which of course we will be working very closely with the state, but we are very, very concerned as to how are they defining, and where do folks who have documented mental health conditions, where do they fall in the able-bodied, if you will. So that being said, don't know the answer to that yet. We're working very hard on that. The other piece I do want to say around work requirements is for able bodies. So those would be people like you and me that are not taking care of children, are not a caregiver for a sick family member, who hasn't been diagnosed with substance use, who is, 65 and over. So there's a lot of different requirements out there. But for folks like myself, who would be considered as an able-bodied individual, I will tell you, we do have some health centers that provide care to the Mennonite community, as well as the Amish community. That being said, they don't have until later in life a birth record. And so if a requirement says that you've got to be of legal status here in this United States or a legal citizen to receive care in a community health center, what do we do about those particular patients? Because many of those patients are able-bodied, right? That's not been given. We don't have any guidance coming out of the government around that. So those are some of these examples. We do have many individuals, especially maybe on the homeless side, that make money by way of mowing a lawn, and they get cash, and that's their demonstrating of working. How are we going to document that? So those are some of the things that we are focused on for those individuals that are able-bodied, according to what's outlined in HR 1. So more to come on that. Don't have a real definite decision on that.
Thank you. And I will just ask one brief follow-up question about this, and then we'll move on to maybe some other topics. But can you just make sure that it's very clearly stated what the work requirement in the bill is? Because I think there might be some confusion about having a job, demonstrated to be looking for a job, the variety of ways that's defined. Do you have any insight there on what we can anticipate?
Well, that is up to the state to decide. One of the things we do know that's coming out of HR 1 that states have to implement is that they are either searching for a job and can demonstrate that, have a job and can demonstrate that. If they're volunteering, they can demonstrate that. We don't know how they're going to be able to demonstrate that. That is going to be up to the state to do that. So that's how you're going to, that's how folks will be able to show that they are able-bodied. If you're a full-time student and you have Medicaid, you will have to demonstrate that you're a full-time student. So those are what we do know that's come out of HR 1, but the more granular requirements are going to be up to the states.
Thank you. That's really helpful, and we should definitely all keep an eye on it. You mentioned a moment ago that Virginia is one of 40 states that, is struggling with some of the same issues about expansion and such. Someone asked, one of our audience members asked, what can Virginia's community health centers, and I would also say Virginia advocacy efforts, learn from other states' responses? How are partnerships between states or partnerships with you and your national colleagues, kind of what are we learning from each other, and what do we still have to learn from each other?
Well, what I can say, being that, I've been in healthcare for most of my career, and I work with a great industry that believes in access to health insurance. We look at access to health insurance, and this is nationally, we look at access to health insurance as access to healthcare services. We are in a country where it is extremely expensive to provide healthcare services. We know that if people do not have access to health insurance, that one critical incident, could really just destroy a person, a family, their livelihood. That's why part of the reason why community health centers were started. But to that point, and to your question, for us nationally, when we all meet, we believe that there is just no other way that individuals like you and me and others can access their healthcare services and remain healthy so that they can go to their job and live a full life. The only way they can do that is by having that access to health insurance. That is extremely important. We do believe that that is that one area that our governments should look to ensuring that residents in the United States have that access. Again, where we sit as healthcare providers is our focus. We want to just keep you healthy because we know that folks want to just live a full life. They want to go to their jobs. They want to take care of their family. They want to go out with their friends. And they want to live a good retirement, if you will. And the way that they can do that is if we can keep them healthy. And in this United States, in order to stay healthy, you've got to have the access to the health insurance.
Definitely. I thought I would kind of start looking through some of the questions from our audience that have to do with a population very near and dear to my own heart, which is our rural residents in the Commonwealth.
Mm,
One of our audience members asks about your familiarity with our rural residents in
mm.
Virginia, especially those in rural areas that maybe did support this administration at the polls when they went to cast their vote. Do you have any sense about their perspective on HR 1, whether they, still feel like they made a solid choice, or maybe that they're kind of reconsidering their perspective on national politics now that they're seeing their own rural communities and healthcare in particular under threat, and also their coverage?
So I will tell you, although my organization represents all the community health centers when we lobby and advocate with our legislators, um, we did reach out to many of our patients and ask them to join us in solidarity to have conversations with our legislators when they were deciding on HR 1. And we had many, many, many stories that many of our patients shared. Now, I will tell you, as a healthcare provider, we don't ask them who they voted for. The only thing we care about and that they care about is their story. I will tell you, many of the individuals that we spoke to that worked with us in meeting with many of our legislators, they shared with us that they were nervous. They were nervous that they were going to lose access to their provider at their community health center, and did not want to lose that access. There were some that shared they didn't want to lose access to their hospital. They call it their hospital. And that being said, we were able to get those kind of stories out there. We do our best at the health centers to keep our communities informed about the sustainability of their health center. And we feel that's the only way that should we end up having to make some tough decisions down the line, that we believe we've kept our community informed because of the reason why we had to make some of those decisions. So I can't answer the question as to whether any of our patients have regrets. All I can do is say, of the folks that we did reach out to, they came and they shared their story, and they're wonderful stories. I love personally rural health. It's a very interesting dynamic to our healthcare system. You know, I've got health centers. I've got one health center, and I'll just say, for the sake of explaining to many on this call, is I've got one health center where I actually have to go into Tennessee to come back in to Virginia to get to that health center. And many in that area, I always know when I get closer to that health center, I lose my cell access. Internet is a struggle. I will tell you, this particular health center decided to invest in solar panels because that is a huge backup plan for them, although they have generators, but still they turn to their solar. And that's really not, you know, that really wasn't around climate, a focus on climate or environmental. That really was about, we got to make sure we still see these patients. And the only way we can make sure we still see these patients is we got to keep our doors open and our lights on, and our machines have to be running. So they made that investment, right? That's the kind of situation we're dealing with. We have situations also where we still have patients that don't have access to clean water. And believe it or not, in this day and age, they do not have access to clean water. We have patients who don't have access to fresh produce because there's that Dollar General that just does not carry fresh produce, and there is no grocery store around. So those are the kinds of challenges, right, that our rural communities are faced with. But I will tell you, they don't look at themselves as a group to feel sorry for. They're proud individuals. They're proud of their communities, but they do want to have that healthcare access. That's important to them. And their health centers are extremely important to them, as well as their hospitals and their free clinics, because that is their only way that they feel they can stay healthy.
Beautifully said. We have some of the same stomping grounds. I also am familiar with losing cell access when I do some of my research. Let's stay in the rural space for a moment and talk about CMS's $50 billion in rural health transformation funds. Do you have any sense that that might be able to assist with the expected shortfalls from HR1? Or let me also tie that to some of the other health systems within the broader scope. So whether that's, rural hospitals or rural free clinics, kind of what might we see from the rural health transformation funds that will help ensure as strong and continued coverage as possible for patients?
That's a great question. And first, I do want to start off by saying we will take what we can get. And we are in some respects pleased that our Congress and administration agreed to have this money available. Now, on the flip side, if you can remember in the last slide that I showed everyone, just the community health centers here in this state is going to lose about $22 million each year that HR1 isn't impacted. And over 10 years, right? Let's times that by 10. This is only $50 billion for all states to apply. Right now, this state is estimating about 100 million will be available to them, but it's only for 5 years. So if you have community health centers here in this state who are looking at around 22 million a year in loss, that's not including our hospitals. That's not including our free clinics. That's not including our private practitioners. Okay? So does 50 billion cover the gamut? No, it does not. And so that being said, what do we have to do as providers, as your providers? Well, we have to be at the table with the state, with our legislators, with our hospitals, with our free clinics, because what we don't want to do is we need to try and prevent any one of us to not having to close our doors or to eliminate services. So we have to lift each other up. And we have to demonstrate to the state that you've got a coalition that's doing everything we can to figure out how we can prevent one person from slipping through the crack. And that's what we're working on now. So will it save us? It will not. But what I can guarantee is that we are trying to figure out as a coalition how we can prevent that one person from slipping through the crack.
Coalition work is so meaningful, and a number of our audience members were interested in terms of the impacts of HR1's impacts on community health centers, and then the knock-on effects on free and charitable clinics, on hospital facilities. I did just want to clarify, are community health centers required to stay financially solvent and prevent bankruptcy? I know that because they're nonprofit, they probably have a little bit of a different operational requirement with regard to their finances than other health service delivery organizations. Can you talk at all about any requirements of solvency?
There is no requirement of solvency. If you can remember, these organizations started out, they're private organizations, they're 501c3s. But like I said, the state does require that you cannot be dependent on this, not the state, the federal government requires you cannot be dependent on your federal grant. Okay, you've got to have some billings out there. You've got to look at diversifying your portfolio. And many health centers do that. But there is no requirement for solvency. You've seen situations where many health centers will collaborate with one another, and you see that. You do see health centers, not here in this state, but you do see health centers that have merged with one another. That happens, and the whole goal or the whole mission behind this particular, why the federal government why Congress approved the Patient Health Service Act, where the 330 Federal Qualified Health Center program falls under, is to ensure that all folks have access to healthcare services. And it is going to be if the feds are going to start this program up, well, guess what, health centers, you got to do what you can to keep yourself sustainable. And when you come in and you take a look at the work that the community health centers do, they do focus on ensuring that they can keep their doors open and they can continue to provide the services they provide.
Well, looking at the time, I'm going to take the moderator's position to ask one more question before turning it back to Dean Gooden or Stephen. I'm not sure who's offering closing remarks. But my question to you, Tracy, is, you talk about coalition in terms of the variety of health services providers. You've talked about the coalition building between community health centers, free clinics, health systems, and then private practitioners, of course. We are also a coalition of people on this Lunch and Learn today, and we probably also have individual contacts. What can individual Virginians do? What can individual students, residents, what can we do to help support the long-term security of community health centers, of health service delivery for all as an important moral issue as well as practical issue? How should we each leave today kind of inspired to take action?
Yeah, that's a great question. The very first thing I'm going to say is no matter what side of the fence you sit on, when you go into the voting booth, I always say to people, vote for your healthcare outcome. That should always be at your top of your list. And I say that because when you're healthy, that means you get to live a full life and you get to continue to go to your job and survive. So when you go into the booth, you should be voting for your health outcome. That's the first thing. The second thing is, please call your legislators. So your federal legislators have now told the states through HR 1, you got to figure this out. So you can imagine you're going to now have very special interest groups, such as the community health centers, through us, going to our state legislators and our state new governor and say, we need help because we've got to make sure your constituents stay healthy so they can still go to their jobs and live a full life. So call your legislators. But call your federal legislators, because the one thing that's outside, that hasn't been decided, is the future of the ACA subsidies. Okay? So the ACA subsidies are set to expire. This will not just impact those who are using them. This is going to impact the whole health insurance market. So for those of us that are insured through our employers, our health insurance companies are already looking at employer-sponsored, okay? So that's why these subsidies are so important, because it not just impacts those who are taking advantage of the subsidies, but it's going to impact our health insurance premiums through our employer-sponsored. So we need you all to call your legislators on the Hill and say, don't look at it for just a year. This has to be long-term. Okay. And then finally, come to a community health center. We provide the best quality care. You can pull our data. It is publicly seen. We provide some of the best quality care. We take care of everybody. Go to a community health center, and I promise you, you will be taken care of.
Thank you so much, Tracy and Dr. Raskin. This was an excellent conversation, and I hope that our audience took as much away from this conversation as I did. I thought, Tracy, you deliver an excellent call to action there at the end, and so I hope everyone listening will follow. Before we close, I just have one quick announcement about our next Lunch and Learn, which is on October 22nd. We'll have Dr. Jennifer Reed, Director of Evaluation at the VCU Wilder School Survey and Evaluation Research Laboratory. She's going to help us understand trafficking in Virginia. So keep an eye on your inbox for that invitation. For those who are looking for a copy of this webinar, we will be posting it to our YouTube channel. And so please, please, please look at your chat box. Our Director of Communications, David, just shared the link to that channel. Thank you all for joining us for lunch today. We went a little bit over. But thank you to our communications team and behind the scenes that's making all of this happen. Thank you to Tracy and thank you to Dr. Raskin. You all have a great rest of your week.